Buenas noches a todos. Es un placer poder contactarnos nuevamente por este medio. Creo que para todos ha sido complicado. El año pasado fue muy difícil, este año empezó de la misma manera, pero de alguna manera tenemos que seguir adelante y rescatar nuestra actividad académica. Y qué mejor que hacerlo este mes de abril con una sesión interesante donde la Asociación Mexicana de Pie Diabético comparte con la industria temas de alto nivel de informativo, de alto nivel académico y sobre todo que nos hacen ver gran parte de los avances que estamos teniendo en el mundo en el manejo del pie del paciente diabético para obtener cada vez mejores resultados cuando esto se requiere. Entonces, sin más preámbulos, agradezco a todos los que se han tomado el tiempo para conectarse esta noche y escuchar una conferencia extremadamente interesante que va a ser impartida por la doctora Valerie Marmolejo. La doctora Marmolejo es doctora en podiatría, ella es experta en el cuidado avanzado de heridas. De alguna manera ella ha trabajado muchísimo en diferentes aspectos del manejo avanzado de heridas. Ella tiene más de 35, 40 publicaciones en revistas de alto impacto académico en el mundo y actualmente se encarga del departamento de educación de una empresa muy interesante que es LifeNet Health. La doctora Marmolejo va a hablarnos del uso de una estructura de un dispositivo biológico que puede sernos muy útil para manejo de heridas y en este caso pues lo que nos interesa es el manejo de pie diabético. Entonces es un placer tener a una personalidad del mundo de las heridas, es una personalidad en el cuidado avanzado de heridas que además ha sido galardonada con diferentes premios en el año 2017, en el 2018, ha tenido muchísimas actividades académicas en los Estados Unidos, en múltiples hospitales muy conocidos, en diferentes universidades y de alguna manera esto ha generado pues que hoy tengamos el privilegio de que ella nos comparta parte de sus conocimientos y de su experiencia. En base a esto, no me queda más que ceder el micrófono a la doctora Valerie Marmolejo y por parte de la Asociación Mexicana de Pediabético decirle bienvenida y pues todos dispuestos a escucharla. Doctora Marmolejo, it's a really pleasure this night with you and thank you very much for accepting our invitation.
Thank you, sir. It is a pleasure to be presenting tonight. So my name is Dr. Marmolejo, and we will be talking about Dermacell AWM. So I'm going to give a little overview first. The agenda for tonight, we'll discuss a little bit about LifeNet Health. That is who recovers the tissue and makes this Dermacell product. We're going to talk about supporting technology that sets Dermacell aside and how it is effective in healing patients. Talk a little bit about the product itself and then summarize. And then we do have some clinical case studies. They are always my favorite to share because a picture is worth 1,000 words. So starting out first with LifeNet Health. So we are a non-for-profit tissue and organ procurement agency. So we really live by our motto of saving lives, restoring health, and giving hope. So everything we do is to honor our donors' gifts and wishes to be able to distribute organs, cells, and tissues. We are the largest distributor of that worldwide. LifeNet Health stands on the 4 pillars here. You can see safety, quality, service, and innovation. I'm going to highlight the safety aspect there. So a big thing when you're looking at your human tissue recovery and processing agencies are the methods that they use for donor screening, making sure that those potential donors that we take, we truly minimize the risk of any potential for disease transmission. And I will say that since 1995, LifeNet Health has distributed over 500 million allografts. So we do everything head to toe, skin, bone, tendon, with no reported disease transmission since that time. So we're going to move right now into what sets us apart with our product, Dermacell. So our product, Dermacell, for wound is human dermis. So it is from skin that has been recovered from our donors that have been screened and tested. We take that from the back, the abdomen, and the thighs typically. And then once that tissue is recovered, we put it through a process in which we can remove donor DNA or those donor cells that could potentially incite a reaction when you place it on a patient. That process is called our Matricell technology. It is patented and it has been validated to remove a minimum of 97% donor DNA. So we've removed those components, but we've maintained the structure of human dermis, the strength and durability, as well as some growth factors or some signaling that can help healing. So the best example I have for our Matricell technology that I usually use is if you took a skin graft from me and put it on you, you will have some type of reaction to that because that graft has my cells in it. Our Matricell process removes at least 97% of those cells. That's what we can measure to. So when you put this on a patient, they see it as human dermis that they can then grow into to help expedite wound healing. So this is important. Here in the United States, a lot of people recover human dermis and process human dermis and make their products. In this chart, you can see 3 different types here: Alloderm, Graft Jacket, and then the Matricell is our Dermacell dermis. And so the different processing techniques will determine how much DNA is removed. And the more of that donor DNA or donor cells in the graft, the greater potential that that patient will have an immunogenic or inflammatory response. That does not mean necessarily that the graft will be a total failure, but it can slow down healing. So if we can mitigate or remove as much DNA as possible, that is great. There is no regulation here in the US or guidance or law that you have to remove a certain amount of DNA. You just have to put tissue through a process. But LifeNet Health has gone that extra step to say we removing 97% or better of those donor cells. So we have nice human dermis, minimal chance of the patient having some kind of response where they have to remove what is foreign in that graft. That just means quicker ingrowth of blood vessels and cells for healing. Our other technology is Preservon technology. So what this does essentially is makes this graft very easy to use. So the graft is stored at room temperature and it does come already hydrated. So there's no need to rehydrate the graft or spend time doing that. It is not frozen, so you don't need to thaw it out and spend the time doing that. It literally is open and apply to the wound from the package. So very easy and user-friendly. So touching on the main features and benefits of Dermacell, we talked about that hospitable graft. So human dermis, we've removed those donor cells. So when you place it on a patient, they will see this as human dermis and readily grow into that graft. Biomechanical integrity. So even though we've put that tissue through a process, it still remains or retains the strength of normal human dermis. So it's still very durable. You can pull on it, you can suture it, you can staple it. It's not brittle or friable or easily torn. It's a very durable graft. We are safe. So we're all about patient safety. We do sterilize this graft. So again, that just mitigates any potential that you're introducing anything else into that wound because we are putting on a sterile graft. And then convenient, again, with that Preservon technology, room temperature, ready to use, just open and apply, super simple. All right, so let's talk about where we would use Dermacell. So the nice thing with Dermacell being human dermis is that it can be used on any wound, anywhere on the body. There's no restriction in that regard. So an acute or traumatic wound, if someone was in an accident and had a degloving where they've lost all that skin, it can be used in that type of wound. It can be used in chronic wounds like your diabetic foot ulcerations, surgical reconstructions. So a lot of our folks, if we do have a patient that ends up needing some type of amputation, whether that's part of the foot or the leg below the knee or the leg above the knee, if there's not enough skin for closure, primary closure, you can put Dermacell on to help prepare that. And it keeps those exposed bone and tendon covered. So this can be used, Dermacell can be used over exposed bone and tendon. It is meant to be a single application product. So one-time application. Here in the US, we focus on patients in the operating room that have been surgically debrided. You have a clean wound, you apply the Dermacell covering, and then it's just follow up in the clinic after that. It's not something where it needs to be repeated applications or coming back to the operating room multiple times. It's meant to be this single application product. We already talked about it being biohospitable because of that matricell technology. So we've removed those donor DNA, donor cells that are foreign if you put them on somebody else. So we mitigate that potential. We're safe, we're ready to be used in the operating room, obviously, because we're sterile, but people are also applying this in the clinic and physician office setting. And convenient. Room temp, open it up, place it on the wound. So the great thing, we already talked about this matricell processing and removal of donor DNA and donor cells. And because when you put this on a patient, it is human dermis, so they see this human to human as opposed to another product which may be derived from an animal, like a porcine product or bovine, something from a cow, that all has foreign substances that the patient has to eradicate first before they can grow into the graft. This study here just shows that with our matricell processed dermis, which is Dermacell, that since the patient sees that as normal human dermis, they readily infiltrate into this graft to help accelerate wound healing. Not only that, but we have blood vessels growing into the graft, so we maintain that normal structure of human dermis, and so you have that kind of vascular roadmap. You know, the outer kind of shell of those blood vessels, that collagen network, that is still retained in Dermacell. So you have a little bit of a roadmap of where those vessels are to grow into. So again, everything to help expedite healing. So we have a study here that looks specifically at diabetic foot ulcerations. This is actually the largest study that has looked at the use of human acellular dermal matrix in the treatment of diabetic foot ulcerations. So this was published in 2017, and it still remains the largest study to date. So we had 168 subjects or patients in this study. And we either had patients getting one or 2 applications of Dermacell. Again, I said it's meant to be that single application. Our study did allow, apologies, don't know what happened. Our study did allow for a patient to get a second application if needed. And about 20% of those patients did get a second application. These were usually wounds that had been present for a long time, so a longer duration, harder to heal. But that's it. We didn't go above 2 applications. So our mean was actually 1.2. So truly is a single application with around about 20% of folks needing a second application. And we followed these patients out. Again, these are diabetic foot ulcerations. So these are chronic wounds. We know that if a diabetic foot ulceration is bigger than 2 centimeters squared, they're at risk for delayed healing. If they have been present for 6 months or more, again, your risk for delayed healing goes up. So these wounds are around 4 centimeters. So they're in that category of these are tough wounds to heal and they're for longer duration. So you can see our healing rates here compared to standard of care, which is just your regular dressings you apply, wet to dry, alginates, foams. And we definitely had statistically significant greater healing at weeks 16 and 24. Now, our definition of healing here was very strict. So to say that a wound was healed, the patient had to have a completely healed wound and then come back 2 weeks later and still be healed. So it was a 2-week follow-up to be determined healed, which is not usually what's seen in studies. Usually they count it healed the minute that wound is completely covered. We are a little bit more strict. So you had to have that 2-week follow-up and still be healed. In addition to that, we also looked, so we healed these wounds. Did these wounds stay healed once healed with Dermacell? And so we looked at these patients at 1 month, 2 months, and 3 months after being declared healed to see those healing rates. So at 1 month, every single patient that healed with Dermacell remained healed. And this was statistically significant compared to our other time points. Once we got to 2 and 3 months out, you're running in the high 90s. And a lot of this is more patient directed. So once you have a diabetic foot ulceration that heals, that patient then lifelong has to take care of their feet, daily foot checks, wearing appropriate shoe gear, that sort of thing. So a lot of recurrence as you get further out is based on how compliant your patients are with those preventative measures. But even with that, we were keeping around 90% of these people healed up to 3 months out. And then in the US, we have a lot of different products that can be used. A lot of these are meant to be applied over and over again. So serial weekly applications. And here you can see in our rainbow colored bars, our 12-week heal rate. This is all from the literature, so has all been reported by these products. And then you can see the cost to treatment. Apologies, I don't know why that's moving on me. So with Dermacell, we have the lowest cost because it's that single application. It's meant to be a one-time. We don't have to apply this every single week like the other grafts. And that's where cost comes into a factor. The more times you're applying more grafts, obviously the more time you're buying or spending money for that graft. But we also had the highest heal rate at 12 weeks. So lowest cost with the highest healing rate. So these were all in diabetic ulcers that were more superficial, so partial thickness, Wagner grade 1s, and then our Wagner grade 2s, which is getting down to joint capsule. Your really hard wounds, though, are your Wagner grade 3 and 4. So your Wagner grade 3 means that we are now down to exposed bone and or tendon. And then you also have an infection component present. That's the picture you see there with the diabetic foot wound with the large abscess beneath that. And then grade 4, we have a component of ischemia. So partial forefoot gangrene. And I'm sure everyone has seen these pictures here are actually patients I have seen. So I know you guys are probably seeing very similar things. And we know that these wounds are tough to heal. They do have a very high related amputation rate just because of the infection component and then the ischemia component as well. So usually these types of wounds are not studied by products because they are hard to heal. You're already kind of put behind the 8 ball in regards to healing. But we looked at this. We had a study that only looked at these type of diabetic foot ulcerations. So all of our patients, 96% of them had exposed bone. Again, we allowed up to 2 applications, no more than 2, and about 20-25% of patients needed a second application just because of wound size or exposed structures, but we still were at a mean of 1.2 applications. So the majority of patients, just a single application of Dermacell. So not only were these deep wounds with 96% having exposed bone, but these were very large foot ulcerations. So our baseline wound size was 29 centimeters squared. So a significant portion of the foot. And what we saw with Dermacell is that all of these patients were able to achieve 100% granulation with a mean of 1 application at a mean of 4 weeks. So Dermacell was able to achieve that granulation tissue covering over those exposed bone, exposed tendon, and those structures, which we know is very difficult to do. Recently in my travels, wounds with exposed Achilles tendon have come up a lot, and they are difficult to get granulation tissue covering over that tendon. And Dermacell works great in these because it's able to act as a bridge to allow those skin margins and the cells and vessels from the edges of the wound to cover over and create granulation tissue over that tendon. We also saw an average 80% reduction in wound size, which is phenomenal. Our biggest wound in this study was actually 114 centimeters squared, and it reduced in size at 16 weeks by 79% squared. So again, you're starting out with a big wound, it's getting to become smaller and more manageable. When I would use grafts in my patient, whether that was a graft like Dermacell, or even if it was a split thickness skin graft, where we got to the point where we could do that. I told them the whole goal of this is to make a big wound a smaller and more manageable wound. So even if this does not heal the entire wound, it's definitely going to make it a little bit more manageable and easier to heal. We actually did have a few patients that did heal in this study with Dermacell. Ones of smaller size, because remember again, we had our mean wound size was 29 centimeters squared, and over half of the patients in our population for this study actually had a wound that was 25 centimeters squared or greater. So smaller wounds obviously healed faster. And the big thing here, if you look at this, as I said, when you have a Wagner grade 3 or 4 diabetic foot ulceration, so exposed bone and tendon, there's infection going on that you have to treat, there's a component of ischemia, these are at high risk for amputation occurring. And if you look at studies, we see amputations rates ranging from 7 to 18% with a diabetic foot ulcer if you have exposed bone or tendon. And this study here, what we did see was our amputation rate was actually able to drop all the way down to just over 1%. And then with our infected ulcerations, it dropped down to that 11%. So we definitely had reduced amputation rates because we were able to get granulation tissue over those exposed bone and tendon structures. So, as I said, LifeNet Health, non-for-profit tissue and organ procurement agency. So we do everything head to toe. In the US and Virginia is where we do solid organ procurement, so heart, lung, kidneys, intestines, those sorts of things. And then across the US, we recover skin, tendon, bone, vascular, we do all of that. Of all the allografts we make, our Dermacell skin, our acellular human dermal matrix is the most studied of everything. So tons of studies. If you ever had a question of how Dermacell would work in a specific case, we likely at least have a case to show you of how that would work. But we did review our largest, we still do have the largest randomized controlled trial to date in the use in diabetic foot ulcerations. We looked at those healing, or I'm sorry, we looked at granulation rate and wound size reduction in those difficult to treat wounds, those Wagner grade 3 and 4 diabetic foot ulcerations, and then cost effectiveness. So we were able to heal patients with that single application. So keeping costs down both for the facility and for the patient. All right, so a little bit logistics, just so we can get to know Dermacell itself a little better physically. So average thickness is 0.5 millimeters, and that is important because that is an optimal thickness for the patient to grow into that graft readily. So anything thicker, the top layer will usually die away. The body can only invade into that graft so much. So that 0.5 millimeter thickness is optimal thickness for wound. We're available in a variety of sizes. So our smallest is a 2 by 2 centimeter graft, and then our largest is 8 by 12 centimeters. We have a few non-meshed versions. They're typically a little bit smaller. And then we have meshed versions. So meshed 1.5 to 1, which is pretty standard. That is the same I would mesh my skin grafts, split thickness skin grafts too. So it's a pretty standard mesh ratio. And then the majority of our products have a 3-year shelf life. It's dependent on size. And again, we are here to honor our donors' gifts. So we are a first in, first out. We don't want to see any product expired before it's used because it's a gift from that person that gave it. So when you get Dermacell, there is technically an up and a downside, just the way that dermis is oriented in the body. So the papillary side is more superficial, so the side closer to the epidermis. And this is what you see in the package. So when you get a Dermacell package, you're able to actually see the graft. It has a plastic window covering. That is the papillary side. And that's what you should see when you put it on the wound. It's a little bit shinier, and it also does not absorb blood. That differentiates it from the reticular side. The reticular side is the deeper side. So in the body, it's this dermal side that's deeper in and further away from the epidermis. And it's the side you do not see in the package. So the side you do not see in the package is the side you put on the wound. This is a little bit duller and it will actually absorb blood. So that's the side you want to place to the wound bed. Dermacell has been put on upside down a few times. It does occur. It's not the end of the world, but it's preferable that that reticular side, the side you do not see in the package, is the side that goes to the wound. All right, cases, my favorite part. All right, so this actually was about a year ago. So this is a case where the patient had foot surgery. They developed an infection and had dehiscence of their initial incision. The doctor actually ended up taking them back to the operating room, opening up the entire wound, treating the infection, and then placed a Dermacell, which looked great. First dressing change around 5 days out, so anywhere from 3 to 7 days out. And it's moisture management after that. So typically patients are seen weekly, and you're just making sure the graft stays moist, doesn't dry out, and does not get too wet. So here we were at week 3, and when the doc sent me this, he did say, you know, the patient developed a little bit of an infection. So I did start him on antibiotics. He was also doing an antimicrobial dressing over top that was being changed every other day, and that was it. He did not debride, just clean the wound, antimicrobial dressing change every other day. You can see we have some exposed tendons, but we do have granulation tissue that's coming up from the bottom aspect of that wound, and it just continued on. So we just kind of watched this granulation tissue grow and cover that exposed tendon and bone, even in the face of this mild infection that the patient did get oral antibiotics for. And here we are at 13 weeks. Beautiful, healed. It isn't even as big as the scar itself, as big as you would imagine it may be, just given the size that that wound was. And so that's all that the patient had. Every other day dressing changes, and just keep plugging along, and we got that wound covered. This is another one. So anterior ankle. When I was in practice, my 3 sites that I found the most difficult were anterior ankle, because you typically have your your anterior tibial tendon or your extensors, something is exposed there. Like you see in this picture, this patient has exposed anterior tibial tendon. Achilles tendon was the other site, because tendons are difficult to get granulation tissue over. And then heel wounds. Heel wounds are another beast in and of themselves. You got bone very close there. Usually there's a component of ischemia, even if blood flow studies show good healing, just because it's a localized ischemia. So very difficult. This here, I like to show this case just to show how this can be used, or dermal can be used to get your granulation tissue over that exposed tendon. So great debridement of your wound bed, as well as your wound margins. So you want to freshen up the edges of that wound and make sure that Dermacell is in contact with that, because it's then going to act like a bridge to help propagate that patient to grow tissue over those tendon. So here they have it in place in the second picture, bolstered down. Dermacell does need to be in intimate contact with the wound bed. It is the wound bed and the wound margins that are gonna supply Dermacell with the appropriate nutrients. And at 1 week out, I always tell my folks, it's dressing changes and moisture management. You really don't want to touch Dermacell as far as debriding or removing or anything like that for at least the first 3 weeks. That is going to give optimal time for that patient to grow into Dermacell. So for 3 weeks, we don't touch it. We do our dressing changes. You can clean the wound, do the dressing changes, and just keeping an eye, making sure it doesn't get too wet or too dry. And then here you see the results at 9 weeks. Not only is the tendon covered, but our wound is dramatically reduced in size and then healed here at 12 weeks. Here's another diabetic foot ulcer on the plantar aspect of the foot. And this image I like to show because we talked about that first 3 weeks, you don't want to debride, you don't want to remove, you want to give the patient time to grow into Dermacell. Around 3 weeks, sometimes Dermacell can look like slough, and it really is around that 3-week time period, which this is a perfect picture. At 3 weeks after application, people get concerned that all the yellow there is slough and tissue that needs to be removed. That is not the case. That is actually the Dermacell graft, and the patient is incorporating into that graft. So if you look at this wound and we assess peri-wound skin, we have no erythema, no signs of infection. The edges of the wound are actually starting to creep in. So we have some epithelial creep where those margins are coming in. And then you can see all those granular buds that are poking in a little bit through the graft and around the corner of the graft. So those are all signs that that wound is healing. And if you had that much slough in your wound, which slough is dead tissue, you wouldn't expect there to be that much healing. So again, we just leave in place. Moisture management, your dressing changes, that's it. I tell people around the 6-week mark, if things are loose or starting to be loose, you can then remove and debride, but otherwise leave in place and just manage with your dressing changes. And here you can see that wound continuing to get smaller around 2.5 months and then healed at that 15 weeks out. This is just another example. What I like to focus on here, this person did have an amputation of the 4th and 5th toes and part of the bone, part of the metatarsal behind that. They used a different type of product to just help build that granulation tissue and fill that void. So this first picture you see here is after they used that product, and they had also applied negative pressure. So they had filled in that void, but still a decent sized wound. At that point is when they decided to apply Dermacell. And that second picture on the top is a great application picture. So when you have a meshed piece of Dermacell, you do want to stretch it out a little bit so you can see those holes, because that's just all the more area for that patient to grow into. And then it's nice and tucked in because you see that wound is a regular shape, and we got to really make sure that Dermacell is in contact with the wound bed. So touching every little nook and cranny, and then bolster dressing. And then they just did their weekly dressing changes after that. So simple, come in, clean up the wound. We don't have to debride, but you can clean with wound cleanser or antiseptic, and then just redress. And here you see at week 7, wound is healed. So again, really the niche, and this here, I wish I had the first picture of it, but this was the entire side of this patient's foot down to bone. So it literally almost looks like a X-ray, a lateral X-ray of the foot. We're right on bone there. So again, applied Dermacell. These are tough because these are diabetic foot wounds. They've been around a long time. This is obviously bigger than 2 centimeters squared. So we're already going to be at risk for delayed healing. We have exposed bone and tendon, so big risk for amputation with that. And here we see at 15 weeks, just the dramatic reduction in size, again with a single application of Dermacell. So 1 application, and then just your dressing changes after that. This case here is also a very good example. So with Dermacell, since we go through the process to remove donor cells, we are removing melanocytes, or the cells that make pigment for the skin. So when you see Dermacell, it's always going to be that kind of beige or tan color. Melanocytes, or the cells responsible for skin pigmentation, are removed. So when you place on the patient will invade with their own cells into the graft. So their own melanocytes will invade into the graft, making melanin. And so skin tone, if you see from left to right of those pictures, actually the difference in skin tone isn't over as large an area as you would anticipate, given the size of that initial wound. And that's because that patient's own cells are invading or incorporating into derm cell. And again, another example. So these are tough. These diabetic wounds, number one, they're large. We have exposed bone. On the plantar surface of the foot, pressure is a big component that is difficult to combat. You know, you have to offload this patient in some capacity. But again, we're using Dermacell here. Good stretch on the mesh. We see granulation tissue kind of poking through all the little mesh holes over there on the right-hand side of the wound. And again, just that dramatic reduction in wound size, where we're then able to salvage this limb for the patient to continue to ambulate, less work on the heart. We know with the amputation, that's going to increase the workload on the heart, which really does increase the patient's mortality rate in the subsequent 1, 5, 10 years. So if we can heal this wound, save the limb, just increase quality of life, reduce morbidity, mortality for the patient. This is another one. So I had mentioned heel. Heel was not a favorite location of mine to heal. Usually it is a kind of localized blood flow issue. And then bone is right under there. So you don't want that bone to become infected. And here we see just that single application of Dermacell tucked in, your weekly dressing changes, just to ensure the moisture management. The very center picture right there, that's 3 weeks. So we don't want to touch Dermacell before then. We don't want to remove or debride it. Leave it in place around 6 weeks if anything's loose. So that bottom left-hand picture, number 7, right there, you're around 8 weeks. You can definitely debride that kind of more callous tissue around the side. That's totally fine. And then we see resolution here at 16 weeks, so 4 months. Some people, you may think that's a long time to heal, like 4 months is a long time to heal. But if you look at heel wounds, even if they need vascular intervention and vascular intervention is performed to help heal that wound, that will take a minimum of 6 months to heal. So anytime I've had a patient with a heel wound, I would tell them this is a 6 to 9 month process of healing. We got to set some realistic expectations. So it's been amazing with Dermacell to see these wounds like here at 4 months. So right there, we're already less. 9 months is the minimum I would tell my patients, or less than that. So anything that we can expedite that healing and get that patient on back with their life is great. All righty, so Dermacell Advanced Wound Matrix, or Dermacell AWM. It is human dermis, our validated, patented Matricell and Preservon technologies help make this a very biohospitable graft for the patient to readily grow into. Also very user-friendly. This is room temp stored. You don't need to prep it at all. It's literally open and apply. We have the science behind it that shows that patients' own cells and blood vessels grow into this graft faster compared to other human acellular dermal matrices. And then also compared to, in that study, specifically Integra, they looked at it compared to. So the patient incorporates into the graft faster, and we have effective healing. So not only healing, but keeping those wounds healed. So that single application, dressing changes typically weekly after that, or it's sometimes the patient's performing them themselves every other day or whatnot, if needed, and then that wound will heal. So that's what we have on Dermacell. I am happy to take any questions. If anything comes up, please feel free.
Dr. Marmolejo, thank you very much. It's really impressive. Have a summary of many new knowledge for us, because we have many problems to treat the diabetic foot. Now I have some questions. Dr. Marmolejo, the question was if you have a process for ulcer bed preparation before use the Dermacell, and which is your protocol for preparation of the bed preparation of the wound before you use the Dermacell?
Perfect. So I'm a very visual person, so I got a picture for you. I'm ready for you. Let's go here. So this was a recent case, and what I see best for wound bed preparation is removing all non-viable tissue. So infected, it's not bleeding, any of that. However you like to do that. So sharp debridement, blade, curettes. Some people get fancy with hydrosurgical, but this here, so this was before debridement. So we got a few areas where you can see it's not red and beefy, healthy bleeding tissue. So you definitely want to take that down. And then the other thing is not just the wound bed, but actually the wound margins. So if those margins are rolled over, the skin's not going to go. So you definitely got to take those down. I would recommend beveling them 45 degrees, or here this person went to 90. Perfect. So making sure you get fresh margins and a fresh wound bed, healthy looking fat subcutaneous tissue. Make sure your muscle's the best thing to put it on. If it's alive, so making sure your muscle's not infected. So basically you're down to healthy bleeding tissue, both the wound base and the wound margins.
Okay, thank you very much, doctor. Carlos, otra pregunta que creo que tú la puedes responder en español es si en México tenemos disponible ya este producto y bueno, supongo que cómo tratar de hacerlo llegar a los pacientes, a los médicos que lo requieran.
Doctor, gracias por la oportunidad. Me pongo a sus órdenes. Carlos Rojas, soy el country manager de la de México y les agradezco esta oportunidad. En cuanto a la disponibilidad del producto, desde hace ya algunos años, hace 5 años, tenemos registrado almacenes de diferentes tamaños y versiones en cuanto a espesor, disponible para el mercado en México. Todos los requisitos están en regla. La cuestión, evidentemente, es el canal de distribución que tiene LifeNet en todo el mundo, es a través de socios comerciales, de distribuidores. Entonces, si se ponen en contacto con un servidor, les puedo dar la referencia de cómo tener acceso a este producto. Pero definitivamente es un hecho, sí está disponible el producto para todo el mercado en México, para todos los hospitales en México.
Perfecto. Bueno, doctora Marmolejo, otra pregunta, or question for you.
Yes.
How often is necessary use more than one dressing?
More than one Dermacell?
Yeah. Yes, more than one.
Okay. So in our studies, it's around 20 to 25%. What I have personally seen, those wounds that typically need more than one have either been because there's been a component of infection present. So they do a second, or the wound has been there an extended period of time. And so then doing a second application. I personally have not seen any that have gone beyond 2. Usually they're very spaced out. So I always tell my folks after the first application, let's wait at least 7 to 8 weeks and see where we are at. And then you can usually tell. The most recent one I've had was a venous leg ulcer that got a second application. They did the first application in December 21st last year, and they just did the second application 2 weeks ago. So they did have a 50% reduction in wound size overall. But this patient's wounds had been present for 1.5 years. So not unheard of to do that second application. They responded well to the first. Just the chronicity of that venous leg ulcer, a second, yes. So probably around 20% of my people, I think it runs pretty decent with the studies. Majority of my people have been 1 application.
Thank you, Doctor. Otra pregunta, other question is interesting. Did you know if it's necessary one training curve or someone number of patients for use the Dermacell with the best result possible?
So for me, I always, and I did this in my practice too, if I was going to use something, and it's usually what I tell doctors to, at least 3 patients, because 1 may be a fluke, but if you get 3, you can definitely kind of get a little bit of a learning curve. The biggest thing is knowing at that 3 weeks that it might look a little scary, like slough. Here in this picture, let me go back up 1. 5 weeks, I mean, that's all still graft. So that's the other usually learning curve part of just knowing what it looks like as healing happens, which is why I stay in contact with docs so they can send me pictures and I can say, yes, no. That's usually the biggest thing. But I always tell them around 3, and usually by then they've got it down and it's a yay or an A, but the 3 gives you a good gauge of how it's going to work.
Okay. Thank you very much. Bueno, en vista del tiempo, tenemos un par de minutos. Me gustaría agradecer a nombre de la Asociación Mexicana de Pediabéticos la participación de la doctora Marmolejo. Creo que nos abrió un panorama diferente, porque siempre para nosotros, los pacientes con pie diabético, en esa última fase de epitelización es cuando tardamos más. Cuando se reinfectan, cuando la herida deja de granular o deja de avanzar los bordes, es cuando entonces batallamos un poquito más. Y creo que esta es una opción interesante y creo que puede darnos un resultado adecuado. Yo me imagino que ya Carlos nos dará la información pertinente desde el punto de vista de cómo obtenerlo, dónde obtenerlo y todo lo que tenemos que hacer para poder llegarnos a este producto que me parece interesante, sobre todo por su origen y como nos explicó la doctora, todo lo que hay que hacer para poder de alguna manera preparar este tipo de ingeniería muy específica y que de alguna manera creo que nos debe dar resultados muy prometedores comparado con toda la tecnología que ella nos mostró y con los estudios que nos mostró que se han hecho de forma comparativa. Pues bien, doctora Marmolejo, do you like give the last words, please?
Oh, well, I appreciate, thank you. I'm so happy that I got to speak to you all. I love sharing about Dermacell, and if anyone has questions, do not hesitate. My information is there. Please feel free. I am happy to answer any questions that come up.
Perfect. Thank you very much again. It's a big pleasure. Carlos.
Yes. Thank you. Thank you.
Doctor, le agradezco mucho el espacio, y si me permite me dirigiré posteriormente en los próximos días a Mexipier para hacerles llegar toda la información que tenga que ver con los canales de distribución, para que quien quiera ponerse en contacto conmigo, y estoy a sus órdenes para informarles cómo pueden llegar a...
Pues gracias a todos los socios de Amexipier que pudieron conectarse esta noche a la reunión. De antemano les quiero pedir una disculpa, pero también quiero decirles que me siento muy orgulloso de darles la noticia de que esta es la primera transmisión que hacemos con este grado de dificultad con la plataforma de Amexipier. Esto es un logro para todos como Asociación Mexicana de Pie-Diabético, y creo que pues los errores que hayamos podido tener en audio, en video, en todas estas cosas que hoy día se ha convertido en nuestra forma de comunicación mientras sigamos luchando todos contra esta pandemia, los vamos a ir mejorando con el paso del tiempo. Vamos a seguir posteriormente con un programa de este tipo de conferencias, compartiéndolo con la industria para ir teniendo conocimientos y accesos a este tipo de tecnología. Nuevamente, una disculpa a nombre de la organización de Amexipier en esta parte audiovisual. Repito, es nuestra primera transmisión compleja con nuestra plataforma, y bueno, creo que iremos mejorando con el paso del tiempo. Gracias, doctora Marmolejo. Gracias, Carlos, por todo el apoyo. Gracias a todos por haberse conectado, y de corazón, un abrazo a todos y nos vemos pronto. Estemos pendientes de lo que viene. Hasta pronto.
Thank you. Thank you.